Welcome to Musings Under the Moon. Musings is about learning through insightful conversations with brilliant minds across the diabetes and healthcare fields. So Musings is a really cool gathering diaTribe has had for 4 of the last 5 years at the American Diabetes Association annual meeting. That meeting's always in June, and all the researchers and so many doctors and nurses and increasingly students and patient advocates and policymakers and social workers, they're all come together to join in about what is the research saying, what's happening in the field, and how can we do better. This year, as I'm sure you can imagine, it's virtual. In previous years, we've held musings the Thursday night before this big scientific gathering. And this year, due to this COVID-19 pandemic that we're all living through, we're hosting musings in a series of virtual events. So stay tuned for the dates on the next phenomenal panels. I can't wait to tell you what they'll be. But these are designed for all of us to learn from each other and from expert minds hyper-focused on diabetes. And I want to say, I know that many of you have been personally affected by COVID-19. Some of you very personally affected from, being sick or having family members who are sick with COVID-19, to unemployment, to challenges with work, whether that's at big companies, small companies, restaurants, grocery stores. My heart is with you. And I just thank you for where you are in this world and for the change that you're working to make. And I'm going to say before our panel starts, this part is a little bit unscripted, but I just wanted to share it. If you're somebody living with diabetes, there's so many ways in which we as patients with diabetes can do better, live better, have better emotional well-being. That's also what tonight in this series are about. And if you're a patient and if your diabetes management isn't as good as you'd like it to be, and I just want to tell you, you deserve everything that can help you do better and to help get rid of some of the burden that all of us have. diaTribe has learned so much and wants to help you get there. diaTribe goes out to, dozens of meetings throughout the year where we get to learn all about science and research. We get to watch so much of what is happening in the field. We're helped by our sister organizations, Close Concerns and DQ&A, in the ways that we do that. And we've really learned so much about, there are whole new ways of using data to learn more, just to learn more about how we're doing. There's technology that can bring us so much more stability and predictability. And, and there are medicines now that can help people with diabetes prevent the stuff that we fear. These are for type 2s. Mostly right now, I think we as people with diabetes, we don't really think of taking medicine to prevent complications, but everyone with type 2 can do that now. And so if you think about preventing a heart attack or stroke, or even, preventing kidney disease, that's actually possible now. And the way that I grew up in diabetes, I've had it now for almost 35 years. I never thought of medicine like that. And there's also medicine that can help us avoid severe hypoglycemia, and medicine that can help us avoid DKA. I'm here to say, none of us ever needs to land in the hospital with severe hypoglycemia or DKA again. I've had 24 visits for severe hypoglycemia alone. There's medicine that can help stabilize us, and there's fabulous next generation glucagon. Everybody should have that, and everyone should be able to go without problems. Everyone should. And I don't know if we all feel like we deserve that kind of life all the time, but it's here for us. And I think some of the problems that we haven't all been able to get that have been in translation. And so the leaders are here tonight to help us think about translation. And there's even medicine that helps us reach healthier weights, if that's a goal. There's medicine that helps us be hungry in ways that feel normal. It's really all thinking about the foundation of data and technology to figure out what we need, and then to figure out if there's medicine we can take to avoid these. And, again, we're going to go through so many different questions tonight where we get to hear from the experts about that. And we just know people in the past, these are called different interventions. It's a new day, and we deserve to learn, and we deserve for this disease not to be so hard to navigate. And all the family members, I mean this for you too. So many of you help us, and no one ever says thank you. And I just want to do that. And I want to say to all of you, there's so much good that can be coming. I've gone to work in diabetes full time since 2002. The changes that have been made in the last 5 years are the best we have ever seen. There are so many, just so much excitement ahead to see what the world will do if we all do our job. These are investments in us as people with diabetes, not costs. And there are exciting days ahead as well, whether that's about automated insulin delivery, whether that's, in the hospital or at home. There's work on stem cells, there's work on beta cell biology, there's work on, the immune system. The most important point, we can take so much more into our own hands as patients if we know what to ask for. So thank you so much to everyone for joining us tonight for this conversation. More than ever, we are really grateful to have the opportunity to learn from each other in community. And as a community, I like being with you as we adapt to new challenges from this crisis every day. Some days it feels like it's with amazing speed, on different pieces of this crisis that are being endured by us, but where the benefits that can come out of it are accelerating. Other days, it's not so fast. It's not so fast some days. Like when we hear that people with diabetes are responding to coronavirus disproportionately badly, that is wrong, and that doesn't need to happen. The longer the pandemic goes on, we recognize the need not just to endure, but to innovate and create more optimal systems and better learning and better listening. And all the patients here, all the people with diabetes here, type 2, type 1, pre-diabetes, gestational diabetes, this world has never been more interested in listening to you. The bar has been raised because in diabetes, we're not doing well. Even individually, we're not doing well unless we're all doing better as a community and as a population, better together. So how do we drive forward? You might say that none of the earlier challenges we'd wanted to solve in diabetes, and there were so many, you might say that none of them have gone away. They haven't exactly gone away, but I think some of them might be easier to address now. I'm excited because the community of people with diabetes can do so much better. Again, the world is noticing that we aren't doing as well as we should, and we all know that we deserve good health and we'll do far better as a system if we can all do our part. How that can happen is part of what we're going to find out in this conversation tonight. In a bunch of different ways, COVID-19 has led to opportunities to address way better than they ever have been for us. Opportunities that bold thinking can propel. And just one of the opportunities is in expanding our audience to all of you. People with diabetes, families, friends, dedicated diaTribe readers, business leaders, healthcare professionals. Even, again, I see a policymaker or two out here. Today, it's amazing to have so many different people from such an expanded field with us, whether it's this morning, whether it's this afternoon, whether it's this evening. Depending on where you're tuning in from. And from the icon that I see here, my gosh, there are hundreds of you online right now already, over 650. And I just warmly welcome you. I love to see everybody here. Again, so many people with diabetes, again, type 2, type 1, gestational, pre-diabetic, people with diabetes in the hospital. We are one. We're the biggest group here, and I'm so happy that you've come. As we all connect virtually to learn, what better topic to kick off our Musings panel series than personalizing care in the shadow of a virtual revolution? COVID-19 is already breaking down so many barriers to access, from telemedicine to remote coaching. A virtual revolution is occurring, and we're probably never going back to the way things were. Let me say that again. We're never going back to the way things were. This change is putting health management in patients' hands in their homes in many ways. And we're so grateful. I remember the moment, that CMS, that's Medicare, said that they would reimburse telemedicine. We heard, from Dr. Mohan in India about how that change happened there in 3 days. We've heard about this change happening all throughout North America, throughout Europe. And we want to know what else is on the horizon. Like, what can that help unlock? Today, we're thrilled to hear from leaders in medical devices, remote coaching, and telemedicine on how to harness these tech revolutions during COVID-19 and beyond into what comes next. So before we get started, just a few reminders. This is so exciting that all of us are on this new Hopin platform. Thank you for experimenting with us. Please use Chrome if you aren't already. which should help with the bandwidth if you're having any problems. Please use the chat on the right-hand side of the screen to ask questions, to make comments, and for sure if you experience a technical issue, so we can get right on it. And when we say ask questions, I mean ask questions of the leaders of their work. We'll be keeping all of the questions and responding to them, even if we don't have time today, and follow-up writing on diaTribe Learn. But please don't ask about things like when certain products will be FDA approved. You know, why did the FDA, when the FDA or EMA decide this, or you know, anything product specific. I'm just asking you, please don't ask us, because that's not why everybody is here. Please be respectful and courteous in the chat, and of course I know you will. Everything you write will be seen by everyone who is watching the event. At the top of the chat window, you'll also see a tab for polls. We'll post questions right there throughout the event. And if you can't stay for the whole discussion, it is being recorded right now, and it'll be circulated to diaTribe readers. So to make sure that you receive that, please sign up at diatribe.org/join if you don't already receive diaTribe Learn. And we would also be so grateful if you would share this with your friends, family, colleagues. Our incredible community manager, Cherie Shockley, I can just hear applause like from all over the world. Cherie Shockley is live tweeting throughout the panel. So we'll be at #diaTribe Musings. So please join us, you know, join the conversation on social media, watch her at diaTribe News on Twitter, and at diaTribe on Instagram and Facebook. And the speaker's social media accounts are super easy to find if you follow Cherise on those handles. As always, I'd like to thank all the sponsors who made this possible. You know, if we were in person, their names would be up in lights. I'm just going to tell you a couple of, just a couple of things about the organizations who are our gold sponsors. That's Abbott, AstraZeneca, and OneDrop. It's a very big deal that they are helping us this much. And in general, you know, if you don't know sponsors directly, be in touch with them via social media, here with us tonight, in future gatherings. Abbott has been working really hard on something called Time in Range. I'm sure some of you using CGM know what that is. Probably some of you using BGM, that's continuous glucose monitoring, blood glucose monitoring. It's been really inspiring. Abbott has been trying to help everyone's Time in Range get better. And that's no matter if we're starting at, you know, 20%, you know, at 40%, even if we're at 80%, but maybe we're doing too much. You know, you can get Time in Range through CGM most easily, but again, through BGM as well. It's a major cultural shift that they and other leaders are propelling. Jeff Halpern from Abbott has been on our board of directors at diaTribe since 2013. I think he's missed maybe 2 hours of one meeting in that time. He is incredibly committed. He is propelling change there with his company through his incredible team. And we are so excited about the work that they are enabling. So AstraZeneca is a company some patients may not know by name, many of you might not know by name, but they've made change constantly. They're thinking about how to reduce barriers for us with diabetes. Almost a decade ago, or maybe a little more now, actually, they bought this little biotech called Amylin. Since then, AstraZeneca has been devoted to making things easier through helping people with type 2 diabetes. Again, take medicine. You know, it's not just about helping us get to the right weights, you know, that medicine that doesn't cause any hypoglycemia, but it's medicine that helps us avoid stuff like cardiac disease, heart failure, kidney disease. You know, no one should ever have to go through DKA and their hospital. No one should ever have to have severe hypo. And, you know, they have had so much success in the innovation and in thinking about the science. And there are other areas, you guys, all their therapeutic areas would kill for many of these findings in science. And so again, we need the data and the technology to unlock some of that, but we can do so much better. They had a trial recently. They had to stop the trial because of ethical reasons. The people who were on the medicine, Farxiga, were actually doing so much better than the people who were not off it. So this is once a decade kind of stuff. FDA has been speeding through changes fast and in making these new indications possible. So it's not, again, for type 1, but for people with type 2, the power is really starting to be with taking therapy. You can start sooner, be on longer. It's going to help avoid complications. And again, that's all about reducing barriers. The last gold sponsor is OneDrop. You have to sign up on their website for their letter if you don't get it already. It's fun, it's funny, it puts a spring in my step. The way that they have enveloped everyone with diabetes into their world has been amazing to watch. You know, when I open their letters, it makes me proud to have diabetes. It makes me feel, you know, like I'm with you all. CEO Jeff Dacus, who you're going to meet in a second, himself has diabetes. He's an amazing entrepreneur who's had a million successes in technology, who didn't have to leave and do anything, and who created OneDrop. And he has so much passion and a ton of interesting ideas. OneDrop is watching out for everyone with diabetes, and they're really shaking things up. You know, and so it's really cool to see so many people with diabetes working at and helping lead these organizations. I'm not sure if it's always relevant how many people with diabetes, how many people who care about diabetes are here at the organizations making things happen. But I just want to tell you, it is so true. We know this is true throughout our silver sponsors. That's Dexcom and Sanofi. For our bronze sponsors, Insulet, Lilly Diabetes, Medtronic, and Novo Nordisk. There is huge commitment and more coming to help people with diabetes in the best of possible ways. And we know people with diabetes are going to need more help than ever near term. And again, as a population, and we're going to all talk now about all of the ways how. But I would like to say, just all of you as a community, you make us at diaTribe stand up taller, you know, kind of make us work more intensely. We are helped by so many other nonprofits in the field. They help us keep our eye on the ball. Specifically to all of the sponsors tonight, it means the world what you are making possible to us as a nonprofit. We send diaTribe Learn weekly now to hundreds of thousands of patients every week. Thank you for your help in growing that number. And to people with diabetes here, thank you for telling us what you want. There's so much that people have been looking for: food, sleep, nutrition, therapies, technologies, and COVID. Just on that alone, check out diatribe.org/COVID-19, where we've got 20 plus stories up. We also wanted to say, if you want to help get our resources in the hands of even more people with diabetes, the Ella Fitzgerald Charitable Foundation is matching all donations dollar for dollar for a limited time. And the URL is diatribe.org/Ella. The sponsors made this free to everyone tonight, and there's no need to pay for any of it. But if you've been touched by anything that diaTribe does for you, or if you might want to sponsor even a tiny gift in someone's name, it'll be matched one for one, which is so amazing. And thank you, of course, to diaTribe for turning on a dime and making what I know will be a really compelling, like a set of very compelling remarks from our speakers possible this evening. So without further ado, I'm thrilled to welcome the following leaders, whom I really regard as some of the best thinkers in the diabetes field today. So first up, OneDrop CEO Jeff Dacus. I told you some of my favorite things about this tech CEO turned diabetes leader. Next, Abbott Divisional Vice President and CMO, Dr. Mahmood Kazemi. I've seen Mahmood speak all over the world. He is incredibly devoted to these tasks at hand. He comes from serving people with diabetes himself here in the Bay Area as a doctor, and I love hearing him speak about the things that he is learning now when he's out in the field helping drive research. Next, Insulet SVP and Medical Director, Dr. Trang Lai. Dr. Trang Lai is helping lead Insulet, as you already know from the slides. I've gone to be in clinical trials with Trang. She's part of kind of what I call the diabetarati that has come out of Dr. Bruce Buckingham's group at Stanford. He's one of the premier researchers of all time in any age, in any generation. And Trang, I think, you know, Trang, I think was really one of the first people for me in a research trial who really helped me feel like I actually deserved to do all right, to do well with diabetes. And, you know, her ability to touch people is just renowned. And finally, Dexcom VP of Medical Affairs, Dr. David Price. I have been talking to David, again, for over 20 years. I might have, I guess I was talking to him in the backstage earlier about this. He was helping me way before I even had thought about going into diabetes full time. He used to be my doctor up in Napa. He speaks, people listen. He is just incredibly, incredibly insightful about our field and all of the changes that he sees taking place. He is so highly regarded. Like the rest of the panel, he's wit smart, he solves problems, and he thinks incredibly creatively for all of us patients. And all of you, I love seeing you here. Thank you so much for joining us. Can everybody hear me? Yeah.
Thanks for the invite.
This is going to be, God, I'm so excited about it. I feel like it's, my family celebrates Christmas. I feel like it's Christmas. You know, I'm going to ask people, you can go to Musing, you can go to diatribe.org/musings to see all of your bios. So again, so impressive. But I'm really excited about the perspective and the guidance that we can offer all of us. So I'm just wondering, first of all, if you can tell me, you know, how do you guys feel at this moment, given the shift that happened by CMS? And again, that's kind of American specific, but those changes happened all over the place. Now we actually can do telemedicine. Tell me just kind of how you're thinking about that big picture and what opportunities that might provide, and what could be easier about it or hard about it. And I'm going to start with David and then move to Jeff and Mahmood and then Trent.
So I think, first of all, I want to thank you for the warm introduction, and thank you for having me participate with this tribe of now over 700 people. So, you know, what an honor. You know, the COVID pandemic has been a crisis, and when I talk to colleagues that are living in the hospitals, it's, you know, you can't even describe the horrors that they're going through. But what it's done is provided an incredible opportunity. So as FDA has allowed CGM to be used in hospitals, and CMS is now Medicare's paying for remote monitoring, it's opened up all kinds of opportunities. So to bring CGM into hospitals to help minimize the use of PPE among the nurses, to help patients play more of an active role in the hospitals. You know, those are just some of the hospital opportunities, and I'll let others talk about some of the opportunities for outpatients.
Thank you so much. The hospital thing is so big. I'm going to hand it to Jeff in a second, but I think what's really interesting, you guys, as patients, I mean, like, people in the hospital have wanted CGM for a long time, the chance to know how we are doing all the time. It was Adam Brown was in the hospital a couple of years ago. If you go to diatribe.org/hospital, you can see what that was like. And it's really interesting to me that this move happened to help protect all of the nurses and doctors. That could never be more important. And sometimes opportunities come, like, when, you know, out of something that we don't even expect, but we can also all think as patients what else we should be asking for. And Jeff, go ahead.
Thanks so much, and I'm so grateful to be here and having everybody from around the world tune in here. You know, it's really an honor, truly. So thank you, Kelly, and thanks to the whole diaTribe team. You know, it's an interesting time. I think virtual care is here to stay, and I think there's nothing that's going to change that. When you've got people that are struggling with getting to the doctor, when you have them unable to see a medical professional, you know, in person or make an appointment or anything like that, really the entire industry has turned on a dime towards really, you know, embracing the idea of virtual care and data-driven decisions that, you know, people, you know, are going to have to make on their own. And so when we think about virtual care, we think about empowering people to make choices day in and day out about food, about medication, about glucose, about physical activity, about all the things that matter to them as a person with diabetes or other chronic conditions, and empower them to realize their own potential in self-care. And I think now is sort of the shining moment where all the pieces of the puzzle start to come together.
Thank you so much. What a statement to think about how, you know, be thinking about how well we can be doing. And that is an amazing leader speaking. I mean, Jeff, you emerge, but like every single year, you see things that just move us so incredibly much. So thank you for coming into the field when you didn't have to. And I love especially that you're on the panel with us tonight as a patient who is watching the field really, really closely in community with these other three amazing doctors. And so with that, Mahmood, any opening perspectives from you?
Yes, thanks again, Kelly, for the invitation to join the panel and to be with all of you today. Really, it's what I would take away from this scenario that we're in with the pandemic is that it's accelerated the reality of bringing virtual medicine to the forefront of care. And this is something that we've really been committed to on the Abbott side for a while in terms of our digital tools that we have for people with diabetes to be able to have these types of remote health interactions with healthcare providers. And I think that, the ability to have CGM broadly now and having increased access through some of the maneuvers that we've seen from CMS, as well as in the hospital, as you mentioned, has really brought the ability to use these data and new metrics like time and range to the forefront of care. And that has, I think, been a major development for us. It's something that we've been striving for. As you know, Kelly, we've been working with you in diaTribe for years now to bring time and range, to make this a new standard. And I think what we'll see now is that more and more people will actually access these technologies, such as CGM, and be able to see the benefits of tracking those types of metrics and having meaningful interactions with their healthcare professionals. And I think that that will be one of the lasting legacies of what we see here with the pandemic that we're experiencing now.
An amazing legacy, and and thank you guys for working on CGM for so long and working on blood glucose monitoring for so long, and helping all of us as patients figure out how to do better. And I love it that you came back in such a big way. And access is so much a piece of what you find most important. I'm going to remind everybody to mute when they're not speaking. And Trang, gosh, Trang's work is the work that she is doing is so incredibly exciting. Watching this MD PhD from Australia come out and seeing everything that was going on at Stanford, and then making the leap. So, wow, Trang, what do you think? I know you're in touch with so many doctors and clinicians out there.
I think it's an exciting time for medicine. I think it's really an awakening, really, for our clinicians and for our patients to really move diabetes care and medicine in ways that we've just not been able to do because of clinical inertia and the way medicine is reimbursed and clinical care is reimbursed. So I love that all of this has made us all rethink, what do we do that brings value to our patients, and how can technology bring value, and how can care bring value to our patients, and getting back to basics, and bring just meaningful care. That's what it's been a huge eye opener for me, and all of that has been very interesting to watch from the sidelines.
Yeah, and that's it's so interesting. It kind of makes me wonder, what else might be possible with data and technology. And I might go back and see if David wants to start us out there. But what else might be possible with data and technology as you guys kind of think about this question?
Yes, I think we could integrate a lot of different types of medical information and be able to combine it to really enhance remote visits. I think it could be used in alternative settings such as long-term care. I think use in the hospital, tremendous possibilities throughout the hospital units, in gen med surg floors and labor and delivery units. I think it could help doctors in rural communities to have endocrinologists be able to look at CGM data and leverage the talents of diabetes specialists. There's a significant shortage that's growing. So I think, the opportunities are endless.
The idea, it does seem like the last few years at the ADA scientific session, there's a younger group of people coming in here. To watch technology can change our lives. It's got to be pretty exciting, especially on the automation front. So I'm going to read all your body language. I'm thinking that my mood might want to come back in here next. And again, I just ask you to mute if you're not, so we don't have your keyboard.
Yeah, sure. I think I'll add in a few points here. As far as actual access to CGM goes, I would say that having the capability of doing these virtual starts is going to be very key, because one of the limiting factors here in terms of adoption of CGM, beyond the affordability factor, which we certainly are striving to do our best with, and Abbott's really been at the forefront, I would say, of that, is the ability to access this technology. And very frequently, that's been sort of the domain of the specialist. As an endocrinologist myself for many years in practice, I was the one who was starting people on CGMs, and it was not something that a primary care practitioner or someone who even saw a lot of people with diabetes would actually consider ever starting. It was thought to be a special device for an endocrinologist to start on type 1s. And what we're seeing now is that is definitely not the case. This is a device that can be useful for anyone with diabetes. This technology of CGM can be useful for anyone with diabetes, and it's not just a type 1 scenario. It's type 1, type 2, gestational, you name it. And I'd say even pushing into the realm of prediabetes from a medical perspective, because what the data allows you to do is empower you to make the appropriate lifestyle decisions. And that is, I think, one of the big legacies of having this ability to have virtual care will be that more people will be able to access this technology, because you don't need to live in a large city or in a place that has a practicing endocrinologist to consider starting with CGM. It can come to you. You don't have to go.
It's a really good point. And I'm just going to jump in and say yes. And I think all of us, I think everybody here has been so focused on access, and you guys have all done really creative work. So thank you on that. I also think that just more on professional CGM, because you said that it allows us to think about our lifestyles, and it is great. Every time I eat Yorkshire pudding, I do see on my CGM what happens, and that's a good reminder. But also, I think there's so many people just haven't gotten to be on the right medicine. So many people haven't gotten enough chance to think about their mental health, emotional well-being. They haven't gotten a chance to think about what is it about their social circumstances that is not working. And it's a mirror. It's a mirror. And so I know also that there is so much as well from blood glucose monitoring that I never took advantage of when I was using a blood glucose monitor. And I was wondering, Jeff or Trang, do you have anything to say on that front? And I'll invite both of you to make comments. And just this question, broadly speaking, like what else do you want to see? But I don't want to forget everybody on blood glucose monitoring, because the CMS piece is one part, and then there's still is hassle, and there's still not enough focus on people with insulin. Anyone, and by the way, anyone on insulin, you should be able to get CGM if you want it much more easily. You can look at diaTribe as a story on that, just about CMS changes by Medicare made last week, and ADA did so much to make those happen. But there's also so many ways that we can be smarter about blood glucose monitoring and what that can tell us. Any comments?
Trang, why don't you go first?
I'm really interested in this. And in fact, we looked at our Omnipod users. We looked at the data that where patients upload their data to Gluco. And we have data from 6,700 patients with tracking their data from January, actually the last 12 months, but from January, February, March and April. And actually during the month of April, after the pandemic was announced, we saw 3 to 4% increase in time in range on average for Omnipod users using CGM, non-specific CGM, which was pretty incredible. And so I wasn't sure what to expect. There's a lot of anxiety and fear in our community, and so it was really a silver lining in all of this, this quarantine and everything, that, maybe at the end of the day, the most important thing is, our health and family and getting back to basics, maybe that, and, reducing some of the kind of material stresses in our life allows people with diabetes to take better care of themselves. So I think it's something that, all of this has taught me, is that, we have access to this data and we should be sharing it. We should be talking about it to help people take better care of themselves.
Totally. Yeah.
We get BG data as well, but there's a bit of a lag time with that. But I'll let Jeff talk about BG.
It's a really interesting question, and thanks everybody for their comments. At OneDrop, we know that the future of, chronic condition care is really digital, it's proactive, and it's preventative. And I want to highlight sort of the difference between what the sort of medical community does in the doctor's office and how we think about patients, and what I, as a person, people do the rest of our lives, the 8,759 hours a year that I'm not at the doctor. I'm just a person. And guess what? I eat food and I take medicine and I have other things going on, and there's some stress and there's work and there's a lot of other things. And so I'm not a patient 8,759 hours a year. I'm just a person with diabetes and a person with a thyroid condition and a person with high cholesterol or whatever. And so I guess what I want to highlight here is the data-driven future that we're all talking about here really needs to empower people, not patients, empower people to make better choices day in and day out about all of the things that are driving, the conditions in their lives. So we have over 10 billion data points on close to 3 million users in 195 countries, powering predictive algorithms that are helping people make better choices. And that's about giving people empowerment. That's about giving people opportunity. That's about helping people reimagine what's possible in their lives by giving them back agency and control and confidence in their own decisions. And so it's important for me to help frame up the discussion here today that what I focus on, or what we focus on at OneDrop, are people. People who have chronic conditions, who need help, who want to become empowered, who are interested in making better choices, and then doing better when they go into the doctor's office to have that support. And I want to stress that it's really important for us to think about people with chronic conditions or diabetes, not diabetic patients or not patients, because guess what? We're not patients most of the year. We're just people. And so I just want to say that if I can empower you with more data and better insights and predictions about what's going to happen to you so that you can avoid problems before they occur, that's empowerment. That's giving back people time. That's giving back people their lives.
And we, you guys, this is somebody who is impassioned, and so I ask everybody else, like, what do you think about that? So like, what else has to happen so that can be put into place? And, this to me doesn't feel like, what else could patients do? It doesn't, I don't know if it's what else could clinicians do. I don't know if is it like, what else would you guys want to see in the system? Like, what kind of system would you like to have? And, I would say, Trang, if you have thoughts on from a systems perspective, or David or Mahmood, any of you can jump in there.
David, you wanted to jump in? You're on mute, David.
Thank you, Trang. Jeff, I want to follow up on one of the things you mentioned about empowering people. So people need the right information. They need to know how to act on it. And I think that's one of the benefits of CGM is people with real-time CGM get immediate feedback. And I just want to talk about real briefly about a study that we're doing. So we're taking people with type 2 diabetes that are poorly controlled on oral agents. And we're doing a study really to see if we can, using CGM episodically, using a real time, if people will be empowered and they will learn experientially from their CGM and improve their control so that maybe they can avoid going on to an injectable medication or adding another agent. So yes, we need to empower people, and I think CGM provides a tool for people to learn experientially about what's impacting their glucose changes that occur throughout the day.
Yeah, and I just want to say before I see if anyone else wants to jump in on that, because a bunch of stuff has been decided for patients, even just hearing like kind of some of the researchers speak like poorly controlled patients where we're only poorly controlled because like somebody told us that we should be taking a sulfonylurea and that's making us gain weight and that's making us have hypoglycemia and that's giving us spikes. And, like the amazing thing, it doesn't have to be like this. But probably more systems change. I don't know. I can't wait to see if Mahmood or Trang want to jump in here. Sounds like my mood.
Go ahead, Mahmood.
Hi. Oh, okay. Go ahead, Trang. I can go after. It's fine. Go ahead.
No, I would just say that, you know, at Insulet, we develop for the patient or the person with diabetes. And so, you know, everything in our innovation and in R&D is about improving life for the person with diabetes. And it's not wholly centered around the clinician at all. And so we are constantly thinking about how to, you know, improve the experience with pumps and to, you know, improve the simplicity and ease of use of the device. And at, you know, right now that has become so much more important with this pandemic and this move to virtual care, to be able to implement safe and effective therapies for people and offer that is hugely important, so that patients can feel empowered to take the best care of themselves and not be limited by options just because of how that care is delivered or how that therapy is delivered. So I'm really proud of how we have always put the person with diabetes at the center of our innovation platform.
Yeah, I love that. And what else is possible? Or Mahmood, did you want to get in there? I don't know if you had thoughts on that too. You were so great just a moment ago and passing the time.
Yeah, absolutely. I mean, I agree certainly with Trang that ease of use is really paramount. That's really the way that you get people to start adopting technology. If it's complicated or if it's expensive, it's not going to be something that people are going to consider. And at Abbott, that's what we've done when we've designed the Freestyle Libre system, is really to look at what is the ease of use factor here. What is it that can make it that someone can literally open the box and start the system without having to interact with a healthcare provider at all? And when we look back on our own clinical trials in both type 1 and type 2 diabetes, it's, you know, now been a number of years since we started in Europe. And when we look back at some of those clinical trials, one of the amazing things is the fact that, to David's point around patient empowerment, people were actually using the system and making decisions and making, importantly, useful decisions within days of starting the system. And healthcare professionals were actually amazed because they thought that they would have to give the direction as to what needs to happen. But the people using the device immediately recognized what was going on and were actually able to improve their own glycemic control because they were able to put into action all the things that they've learned over the years, but which have always been very difficult to do without appropriate monitoring. So this is really, I think, one of the testaments to what, you know, virtual care will really allow us to get more people on these devices and make these small changes that can have a very big impact in the long term.
Yeah, I'd like to add to that, if you don't mind, Kelly.
Yeah, go ahead.
So, Mahmood, you made me think back to the original 3-day CGM and experiments that were done where they had blinded CGM and then unblinded CGM, and you could see the glucose variability decrease within days. And if you carried it out another 3 days, it even improved further. So yeah, people get it. They could figure it out pretty quickly. Just one other innovation that I wanted to talk about, and that's one thing that Dexcom has developed over the last year or two, which are our weekly push notifications. So for people that are using the app, they're able to get notifications of how their time and range has changed on a week-to-week basis, what their glucose patterns are, what their best days are to help motivate them. Hey, this is what you did that would work. And we think, again, we are that this is a tool that is really helps empower patients to better self-manage their diabetes.
Yeah, you know, it's funny. Someone said to me recently, I'm lucky enough to be able to have not only CGM, and I am grateful for it every single day. But I wasn't using BGM in the right way back in the day. Somebody recently said to me, because I'm lucky enough to have automated insulin delivery. I mean, I think everyone who could benefit from this deserves to have it. You know, this is not going to be today, but there's so many people obviously who aren't on insulin and never need to be on insulin, and so that's also the power of you know, just it's more about like what you guys are all talking about. It's different tools, but it's the data. And I know, like, I kind of used to be scared of it, or I didn't think I could do it, or I didn't think I could necessarily be successful. And it's so much easier now. It feels like on the BGM front, there are more opportunities to get it, but sometimes maybe it's like some doctors themselves don't feel like they have time. I mean, what doctors are doing to keep patients healthy right now, it is insane. Just the demands put on them. And so I was wondering if you guys could talk about that a little bit. Will the pandemic kind of accelerate or decelerate kind of the uptake of things like getting data from BGM, CGM, stuff like the standard, AGP reports that aren't being used that much yet? And I'd like to hear that. Yeah.
I was going to say, are we talking about getting data to doctors for treatment
Yeah,
decisions, or are we talking about getting data to individuals to empower their own self-care?
I think it's both. It's so interesting to hear you guys talking, because some of this stuff, it's like therapy is foundational. But if you're on the wrong therapy, like, if you should be on, once weekly GLP-1 and you're on a sulfonylurea or metformin, like it's going to take you can empower me, but like I might not know, right? And I'm curious. Some of those questions are about like what can patients look at with doctors. But I love where you're going. You were a million miles ahead of me there, Jeff. So I'm going to hand it back over to you.
Well, it's really interesting because I think there's a bunch of data out there that makes sense for people as inputs, right? Food and physical activity. Medication is what you do to treat the symptom of the choices that you already made, right? And insulin is such a blunt instrument that it's really scary for some people to be dosing their own insulin, and then thinking about the cost and access of automated insulin delivery or some of the more automated systems. You really have such a huge portion of the population that needs to be thinking about adjusting the inputs, and stress and sleep and food and activity, and then thereby getting to the right therapy post good decisions. And so with the right data empowering that individual, they can really make better choices in terms of the downstream treating of the symptoms of some of these conditions. And I just want to make sure that we're not just talking about CGM powered insulin delivery, because in reality, the large portion of the population really has to focus on potentially that, but a whole bunch of other things
for
too.
sure. And thank you for bringing us back to that point. I guess I get kind of upset when things are talked about as expensive, but like I never hear dialysis talked about as expensive, like or heart attacks or strokes or like amputations. Like let's see some of those curves, because these are investments in patients, like they're not costs. And by the way, there's a ton. So many patients will be able to do so much better with professional CGM, and then go straight back to blood glucose monitoring. And then how do you use it? So others want to jump in here.
I'll add in a few things, Kelly. I agree that the power of data is what's being brought to the forefront here in this situation with virtual care. Because if you think about it, at a regular office visit, for example, when I was in clinical practice, we would with them. We would really, really strive to get some blood glucose data at an appointment. And we were lucky if we got at least a few days worth before the visit. And so we were making decisions essentially on lab data, A1Cs, and we were making decisions based on other things that we had available to us. Well, guess what? In this type of an environment, people may not have the opportunity to go to the lab. They may not actually have the opportunity. You don't have the opportunity to do a physical exam, for example, because you are not right there in front of the patient in many cases. So what you really have to rely on is the ability to look at glucose data and to come to meaningful conclusions based on that. So far as we are able to adopt greater access to having this glucose data available, that will make these types of virtual encounters much more meaningful and productive. So I think that this has really brought the importance of glucose data to the forefront of what we do in diabetes management.
What would you guys like to see done differently for the doctor's offices in terms of, the kind of empowerment they have and, what they're able to do? This is a labor of love. I am so grateful to doctors and nurses and the people, obviously the people who are on the front lines out there on COVID-19 and diabetes, like what would make their jobs easier in doing this? And I don't know, Trang, if you have anything to start on that, or others can let me know.
Yeah, I think that a huge limitation of where we're at now is having to upload pumps. And so we are launching our Omnipod Gluco cloud to cloud integration coming out actually next month in our next version of the Dash, which all of our patients will be eligible for. But that data will go immediately as to Gluco so that patients can then access through their Gluco all their data. And so that will happen, as long as you're connected to Wi-Fi. And so, that is a significant investment for us, but we thought that it was important enough because it reduces the time in the office that the doctor and the care team has to spend in uploading devices, and makes, then allows them to be more effective in the care that they are able to deliver to their patients. And then also allows patients to use, a really good platform like Gluco to take better care of themselves. So,
yeah,
Gluco's also been an uptick as well in terms of user engagement with their apps during COVID. So I think people are trying to take better care of themselves.
Yeah, totally. David, what do you think about that?
I think one of the questions you ask about systems, and we really have a system problem, and it's those damn EMRs. So right now, people could.
What's an EMR again?
Oh, sorry, an electronic medical record for those that may not know. So when your doctors are busy typing instead of talking to you, it's all about EMRs. But the issue is that yes, people could review the data in Clarity or Gluco, but you can't get it into the electronic medical record easily. So there's a number of barriers put out. There's not a standardized way to do it. There's some middleware vendors that help with that. But if diabetes specialists are going to be working with remote clinics, with different systems, different offices within their health system, getting data into EMRs is essential. And I think one of the learnings actually going into the hospital is the hospital environment. It's absolutely critical to be able to get CGM into EMRs. And there are so many barriers to doing that right now. So I think that's an area that needs to change, and hopefully that patients and regulators and government could come together and really simplify getting blood glucose data and CGM data into the electronic medical records.
Yeah, I mean, maybe Jeff can bring over more of his friends who are working in tech, but it's really, I mean, it's people who are in every other field and looking at diabetes as a, multi-stakeholder condition to address it. That was really news to me, how important that was. Are you guys optimistic about getting time in range into the electronic health record, and that can be from blood glucose monitoring? Maybe it's more results in range there, or how do you guys think about that? How long do you think it'll take, and how much could that help?
I think that's happening now, right? I mean, people can't get A1C, so doctors are using it as a surrogate measure, using estimated A1C from CGM or from BG. I mean, the data is good in terms of the correlation. I mean, obviously, you get a lot more readings from CGM, but it's what we have right now. So people are using it.
Yeah.
It's interesting to think about CGM as a movie, where you get BGM as a snapshot, right? And so it's really interesting to see snapshots in the past or a movie of my past. But what's more interesting is to think about what I could do with the data that we're talking about to predict what's going to happen and avoid problems before they occur. Advanced collision avoidance for people with diabetes and chronic conditions. And if you were going to run into the tree and your advanced collision avoidance system could tell you how to avoid it, you probably would. But today, there isn't any systems in the market that are telling us what's going to happen and how we can make changes to not have bad things happen. And so, it's really great to let AGP or Clarity or through all the great systems that we have right now to show movies to medical professionals about what happened to me. But again, I want to refocus on empowering the individual to avoid problems before they even occur. And the data is really valuable in both contexts. It's really valuable in a retrospective movie where we can see what happened and potentially adjust things where we saw problems. But not everybody's life is the same every Tuesday. It's like, oh, on Tuesday you had a problem. It's like, well, this Tuesday is a whole different day. The future, every future day is different than today. And so what I want to do is figure out how to solve problems before they occur so that I don't have these collisions, when they do. And anyway, that's what I think the power of this data is going to be. It's going to be about preventative, proactive, prospective self-care.
Yeah, I know we're really hearing you on this, and especially on the, on the prevention part of it, and and I think it's like preparedness, right? I guess I want to see if I can switch gears with you guys a little bit. We'd love to kind of talk about your experiences with virtual visits for patients and for healthcare professionals. What's kind of working that's notable that could be taught more widely on telemedicine? What's working less well that could be changed? Just kind of thinking about creating maybe a best practices guide. We know that, so many populations are really heterogeneous. But what would you say? Like, how's it going so far out there from your just word on the street that you guys have got?
I can provide a few anecdotal bits here, Kelly, because I think obviously a lot of us are just in the midst of what's happening. But I can say that what seems to work well from providers that I've talked to is they actually sort of have composed almost like a checklist of things that they would like to have ready for these virtual visits in order to help understand what needs to come into the visit to make it productive. And especially when it comes to diabetes, that involves having access to glucose data, right? So I think that one of the things that's worked well is to make sure that the individual has been consistently using their CGM in this case, since we're CGM perspective, for at least the past 2 weeks going into a visit, because we know obviously from studies that others have done that 14 days of that continuous glucose data is a key factor in helping to understand and predict what A1C and glycemic management can be in the future. So to Jeff's point around sort of, what can we do to help improve the future? Well, to some extent, we have to look to the past to help serve as a guide, but not to indicate that it's the only inevitable outcome that could occur. But we can use that data to help steer toward a better future. And having glucose data, having a clear sense of what questions you want to ask at these virtual visits, because they do tend to be, of course, much more focused, and having a much narrower time window can certainly help provide better context and better outcomes for these types of visits. So I would say that having that data available at the point of the visit is really key.
Yeah, and so we go back to some of those questions about what are the best ways of doing that? And it's probably not necessarily the most experienced all the time who are making that possible. But does anyone else want to jump in here on just stories they've heard of what's gone well in virtual visits? We have on diaTribe's YouTube channel 2 amazing perspectives of some fantastic people in the field urging patients what to do. I wonder if there's anything about urging doctors and nurses what to do.
So one of the things that we have heard is that with virtual visits, it's not just the patient and maybe somebody who drove them in, but you could bring a lot more people into the visit. So I think that's been an area that's been fruitful. Or if there are 2 divorced parents living in different cities, they could both participate in the visit. I think another benefit, I want to come back to the HCPs, is, for those that have figured it out, so the two endocrinologists that figured it out across the country, they're thriving because they can now bill for care that Mahmoud and I and Trang provided for free. So figuring out how to code to make sure it's billed, to make sure that patients are aware of the charges and are going to be responsible for copays. So to really go through, people that are most successful are those that the 2 endocrinologists that have established these processes and they're using those processes in a way that is that they're able to adequately bill and get compensated for the time for the remote visits.
Yeah, a friend of mine said yesterday that he heard that his doctor had been, I think this was a psychiatrist, actually had been paid $1.06 reimbursement for the visit. So like we're not all there, but Trent, go ahead.
Yeah, I think reducing stress for the families and is something we shouldn't underestimate. We're doing virtual trainings with our Omnipod, and one of our trainers sent around this photo of a mum and two boys, and they were just so happy to be able to do the training for 2 Omnipods on 2 boys at home in the comfort of their own home, and not have to bring the whole family, and mum has to take time off work. And I mean, there are significant things, and get parking and all of that. It is very stressful for families to get to see the doctor. And so the potential of offering that to so many more people in remote places, where endocrinologists are just, the underserved, is just so important. So I think, as long as we're focused on reducing the stress for patients and families, I think it's always going to be a good thing.
Yeah, I love that. I just wanted to jump in and ask a question about that. I was listening to a bunch of doctors talking about this recently, and they were like, yeah, but the facility fee isn't paid, and I'm like, I don't know from facility fees. I don't really know what that means, but I do know like all the training right now is in the hospital, just for medical school students. And I presumably that's something about the cost of hospitals. And my God, like I'm so grateful that we have the strength of the great hospitals when we need them. But this is also another thing that Trang is talking about. Like they did better and it was easier at home. And so that doesn't seem 100% aligned necessarily with this kind of acute care focus for the system. Not to bring a loaded, depressing question to us all. That's not exactly data and technology, but it sort of is. Thoughts on that, Mahmood? Do you want to start?
I think that, yes, I mean, I get the point there that certainly the interactions that we're seeing now in this sort of a virtual world are quite different. But I think that, as Trang mentioned, it's really important to sort of make this about the patients and what they can take away from these visits. Because I do think that when you have an in-person visit, example, in my own personal experience when I was in practice, there are many other things that can occur in an in-person visit that you can't. So for example, let's do something as simple as educational materials, right? Oftentimes offices are already having educational materials that you can simply hand over to the person while they're there in the visit. So how do you approach that now in a virtual setting? Well, one of the key things that we've done, again, at Abbott is that we've really tried to provide an array of tools that are available to people living with diabetes that they can access on their own time. And certainly healthcare professionals, we've explained to them what these tools are and allowed them to simply use them with people with diabetes in the midst of this pandemic to allow and not make sure that that education goes to the side of the road here just because they don't have the ability to access the educator perhaps in person or to come to your office in person. So you really have to be creative and find new ways around diet, around activity, especially given the challenges with activity in our current setting for people with and without diabetes. It's just very difficult. Yeah. But one of the key things, one of the key things I think that has come from this is the ability to try different dietary regimens, right? Because we're all stuck at home for the most part. And so you can actually have access to different kinds of foods and things and try out and see what works for you that you may not have had the ability to do before because of your work schedule, other commitments, etc. So there is some positives to be taken away in the midst of what has been unfortunately a very negative scenario.
Yeah, Jeff, what do you think about that?
Interesting. OneDrop's been virtual since the beginning, and all of our care is delivered virtually. All of our educational material and our programs are delivered virtually and are available to users 24/7/365. All of our coaches are available 24/7/365. And so, users don't have to rely on the episodic virtual visit, if you will. They always have their ally, their diabetes ally, in their pocket with them all the time. when they need to make a choice at the wedding about the wedding cake, or when they need to make the choice about the visit that's causing stress with their divorced husband, when they need to make these choices, their coach is with them all the time for a visit. They don't need to wait for an appointment. They just, text their coach, and all of the educational material around activity, around sleep, around stress management, around nutrition, around alcohol consumption, around all the questions around sex, around all those things are available, right there when they need it. And so, we're helping them make decisions day in and day out, incorporating behavioral interventions, incorporating cognitive behavioral therapy, commitment therapy to help people make healthy choices. And that's really where the person lives with diabetes and other chronic conditions. And we're from the beginning. And by the way, let me add one more thing. All of the data that the user generates is available to their coach in real time. They don't have to wait for the download. You don't have to wait to upload it to the cloud thing. It's available instantly to the coach immediately right now. Yeah. The second you start, the coach is doing your data immediately. I think what we're talking about is a complete paradigm shift into the way people engage in their own self.
I know, I love that. And you know what? Like, you're helping us be our better selves and actually help us see that we deserve to do that and that we should do that. David.
Yeah, I just wanted to chime in on the training aspect. Dexcom has an incredible group of educators called Patient Care Services Team, and they really help onboard people with CGM that have difficulties. A lot of the Medicare population accesses it. So yeah, we've been doing a lot of supporting a lot of remote training, and I think that that's increasingly important in this particular environment. And to Mahmoud's point, you need less training the simpler the products are. So it's an ongoing focus for I think all of our companies, certainly with Omnipod and Abbott and Dexcom, is trying to unburden users and make products that are easier to use, that require less training and less instruction.
Yeah, and I love that. That reminds me of something that Bob Gabbay said not too long ago. We were in a roundtable session, and there's a lot of focus on the elderly, and there should be, but do we want to relax the A1C guidelines and all of that? And he just said, how about reducing burden? How about giving people the data, and this will also be better for all of their caregivers. So yeah, I love that, you guys. What would you say, they're cool, these are amazing things for us to be able to work with, just culturally? Can you say anything about what needs to happen out there? And this could be culturally, with healthcare providers or with the government. Even thinking about ROI, is that ROI near term? Is that ROI longer term? Just what else do you want to see? And this kind of gets at even when we think about, a year from now, what do we want to all say that we did as a result of this pandemic a year from now? I'm going to end, when we get to the ending in 22 minutes, I'm going to ask you what you want to see 20 years from now, that we all did and made happen. But is there anything on that front, to speaking to the culture?
I'd like clarity on the question.
Mike, I'll do it. So I think it's everyone coming together. I mean, so I think that's one of the things that's come out of this pandemic, is that you have the FDA, you have CMS, you have payers, you have clinicians, diabetes specialists are probably working closer and with hospital systems and non-specialists than they have in quite a long time. So I think it's the coming together of the diabetes community, and I don't want to exclude patients. I mean, but I think that's one of the things that, I'd like to look back 20 years from now and say that, hey, this was the spark that really brought the community together.
And I'll also add, oh, sorry, I was going to say that I'll also add in that I think that culturally, oh, sorry, Kelly, go ahead. There was a bit of a delay there. I was going to say culturally, I think the key thing here is that right now we sort of look at a virtual visit as, before virtual visits as an exception. In other words, we would tend to say that you have to come in person, and if you had a good reason, we could do a virtual visit. I think what really needs to change culturally is that it's actually acceptable to have mostly virtual visits if you'd like, and then maybe have an annual in-person visit if you're doing well and you just need to check in on an annual basis to maybe check on exam features, etc. So I want to see the day where it's in fact the opposite, that you have to have a reason to come in person if you have to. So I think that's what the cultural shift will be, that it's very much not acceptable, but recommended that these virtual visits occur in the future.
Yeah, I think we're all in this together. I mean, we are all in this together. We are all fighting, hopefully, the good fight. And, yet we all have our head down in our swim lane sometimes. And so when thinking about this, like culturally, I think it's really important that, we put the people with the condition first, not the revenue model, not the regulatory framework, not the HCP channel or whatever we need to be focused religiously on the people that have the condition. And there's a lot of talk about patient centricity, but I think now, hopefully this is an opportunity for us as a catalyst to make that a reality.
Yeah, that's exactly right. And I like hearing that piece about the catalyst. I want to hear a little more about that right before we go to audience Q&A, but I can even see some of the stuff in Q&A and the things that we've been listening to. People out there want to know. They want to hear, about what you guys think about the opportunity we have to support patients who need maybe the most help with, I guess, what's called kind of complex diabetes, adults with diabetes on Medicaid who are relying for diabetes care, outside of specialty care clinics. How to pivot and leverage some openings during this time of COVID-19 to support urgent needs and get them access and utilization to diabetes technology when, maybe how you accessed it before isn't the right thing. I loved seeing last week when Medicare said, okay, maybe you don't have to have, 4 finger sticks, in 14 days to do this. I would love to see, more of that across the board. And I wonder about what you guys would like to see as we think about, again, the people who have the least, Yeah,
I would love to see people having access to therapy sooner and having that option much sooner and not have to jump through hoops for everything. I heard of a case of a type 2 patient. So about a third of our Omnipod new starts now are actually type 2. And this one gentleman who just started on the Omnipod had 1% time in range, Kelly. Like isn't that like,
oh my gosh, wow.
Like kind of heartbreaking, right? But isn't it wonderful that like somebody said, look, you want to try this therapy, it might be good for you. And here is like an affordable, pump that you can access through a pharmacy channel and you can try, and it's not going to be huge upfront cost for you.
Yes.
But really wonderful to hear that people are having the opportunity to have that access. And I'm grateful to hear those stories.
Absolutely. I love that. I know people sometimes say to me, oh my gosh, like when you used to work on Wall Street, what was your time in range? And it's like, I don't know, because I didn't have a way to think about my results in range, but I bet you it was about 20% or something like that. And so again, whether someone's using blood glucose monitoring, whatever they're using. So that person, I don't know if that was, so maybe someone with type 2, they probably weren't even on insulin, and getting to see how much better they can do is so exciting. We were just so moved when we were hearing some of those numbers, Trang. I'm going to go to some audience questions, but you guys feel free if anyone wants to also add to that eloquent perspective from Trang, let us know.
I just want to add real quick, accessibility, affordability, and soon, we'll be seeing effectiveness. And, the idea that you need, this whole set of systems, to make decisions about your care, or have your health practitioner help you make decisions about your care. We need to start driving towards accessibility, affordability, and effectiveness on mobile phones, because we can reach such a huge portion of the population with a diverse set of communications, education, information, and data to empower them to make better choices, to take back their lives, to have confidence, and to imagine what's possible.
Yes, and to imagine what's possible. I bet this person who had 1% time in range had no idea, probably even, maybe even what time in range was. And so it's also, I love hearing all of that empowerment for healthcare workers out there as well. And I'm totally following what you're saying. In fact, Jeff, I think somebody was channeling you out in the audience. Crystal Lane asked in the chat, prevention is not a word that drives healthcare in the United States. And so, what would you guys like to see on the prevention front, on the preparedness front as we move forward? And thank you, Crystal, for that. David Mahmood saying, Jeff.
That's one thing that automated insulin delivery actually does. So automated insulin delivery systems that are out there in development, that is a prevention. So it prevents time low and it minimizes time high. So I think, automated decision support, automated insulin delivery systems are going to be a tool is another method of prevention. There's lots of ways to get at it. I think an emerging technological approch that really will minimize hypo and hyperglycemia.
Yeah, I get it. The minimizing hypo. I have Riley a link because this is one that I started with. I'm excited to try them all as they're ready. But the fact that I can go like this, it's this soft landing, and you guys, I could cry. Because you just don't get that swing up from an overtreatment. But you get that swing up if you decide, it's midnight and I just feel, I don't know how these ruffles got in the house. I'm going to eat them. So the part about the hyperglycemia, I don't know as much about, and maybe that was also something that Crystal was thinking about, what other investments might we want to see in the community, in municipalities, in food, all of that. I don't know if you guys have thoughts on that, but I am totally with you. The chance to get to automate insulin, and some of that could be, through pens, some of it could be through smart pens, some of it could be helping them understand they need insulin, but the exquisite way that you can do it with continuous insulin delivery is pretty powerful. Other thoughts on prevention of mood?
Yeah, certainly. I think that hypo and hyper have their place. And I think that one of the big targets in terms of prevention is also minimizing glycemic variability, because we're getting increasing evidence about the relationship between glycemic variability and various undesirable outcomes. Their target, especially with the use of CGMs, is to help minimize those excursions, which are certainly no fun to live through for people living with diabetes. But on top of that, it actually can have untoward health consequences. But I would say, in terms of thinking, when you look at prevention, Kelly, one of the key things to be looking at is how do we actually use these technologies to help prevent people from developing type 2 diabetes, which we know is a major public health issue in our country.
Totally.
So if we're thinking big, what can we do to actually prevent prediabetes from becoming diabetes? And I think there's just so much that can be done from the CG in terms of helping to guide appropriate lifestyle interventions that we all know are effective, can be actually more effective than pharmacologic agents in the prediabetes stage. So how can we leverage these tools to help bring it to those people who can benefit from it and help curb the flow of people going into diabetes? But I think that's going to be another major use for these technologies.
Yeah, I think that's as well what I'm probably talking about, even the hypo, curbing the hypo and hyper, again, whether through BGM or CGM, but that also then enabling prevention of the long-term complications that really scare all of us. Trang, did you have anything to add to that one on prevention? I feel like there's so many amazing things that your technology is helping prevent by the day.
Yeah, when I talk about pump therapy as a pediatric endocrinologist, I say, well, it's about instituting care as quickly as possible, as early as in the disease processes as possible, to ensure that metabolic memory that person has for good glycemic control and optimal time in range can carry with them for the rest of their lives. So that is the urgency that I try and convey to our clinicians about instituting therapy early on from diagnosis. And I think in terms of type 2 and prevention, I think hugely underserved population and underdiagnosed. And, we prescribe a lot of insulin and a lot of therapies, but it's really hard for people to understand and actually take that complex regimens. So I think simplicity is really important in whatever therapy the physician is prescribing, to ensure that people can actually have that. So when we talk about data, we shouldn't undervalue the insulin data that is coming from a pump as well. So when you're doing your virtual visit, it's CGM, BG is important, but also that insulin data is important.
Mm-hmm. Yeah, I want to move back. We had an amazing question come in from Tara Smith from Beyond Type 2. And thank you to everybody in the audience for giving us so many cool questions. But she wants us to circle back on this piece about elderly patients and just to buy in to virtual visits. One of the things about COVID, like maybe grandkids or kids like aren't around to help. Do you guys have other thoughts on that? Because all of you are serving older people and the elderly in so many ways. And maybe David, to ask you to go first, and then Mahmoud, Jeff, and Trey.
Yeah, I think the issues of access or getting into a clinician's office may be even that much more challenging for some of the elderly people who may not be able to drive. So this is the opportunity of remote patient visits where, again, not only the patient could come in, but other caregivers and family members. I think it's the remote monitoring capabilities, the telemedicine capabilities may be really important for that population, for seniors.
Like if they just get to practice it or try it out. We'll try to get more views on this as well. I know that we at diaTribe keep hearing from doctors who themselves are not really in systems that 100% necessarily are propelling them toward virtual visits. And so I think maybe some more encouragement there as well. And if there are other thoughts on that one, obviously, please let me know. I know
visits don't have to be just an appointment, right? We have users at OneDrop, that are elderly that absolutely know how to text their granddaughters or their sons and daughters, and they can just text OneDrop in the same way and text their coach and get predictions in the same way. And so, I just want to highlight, like, virtual visit in terms of a visit at a set time with the doctor, isn't really, I think, the paradigm that's going to work going forward. It's going to be this always on asynchronous set of communications that allow people to connect when it's convenient for them, when it's the right time, when they have the opportunity to take a break, when they're waiting on the bus, or when they are in between school things or whatever. We really need to start thinking about virtual care not as these episodic visits, but as something that's ongoing, that's living and breathing as part of somebody's dialogue with their care professional.
Yeah, and that's really magic. And again, I mean, I want to say, like, it'd be amazing to also have the feeling that the doctors and nurses all felt that they were really supported. You know, I guess I got one more audience question here is this whole piece of, you know, if you could say one thing to the people on this call. It's funny, somebody actually texted me this question, so I'm not sure if it should have on chat. But you know, if you guys could say one thing, let me know what it is. I am gonna ask you then to close on, like, where do we want to be as a diabetes community? You know, where do we want to be in 20 years, looking back, showing what we did? But maybe first, because there's so many different people on the call, you could start with, what's one thing that you really want to say to people? And maybe, Jeff, I'd start with you and then go to Trang and then Mahmoud and then David.
One thing I would say, let's all, you know, transform healthcare. Let's give people back the opportunities in their lives so that they can, you know, receive all the blessings that are right here in front of them when they're not so burdened by managing these chronic conditions.
So beautiful.
It's a tough one.
Oh, sorry, hang on, David.
Yeah, no, that's a tough one. I think, you know, I think everything's going to be okay. You know, we're all going to get through this together. And I think the important thing is that we take care of ourselves and our families, and the rest is going to sort itself out.
Yeah, from my end, I would say certainly one of the important things here for everyone on the call is know your options, be informed. You're your own best advocate. So please, it's obviously a challenging time for everyone, but don't just give into feelings of hopelessness. Go out there and know what your options are. There are many resources that can help bring information to you that will help give you a sense of control to whatever for the situation. And again, you are your own best advocate. Know what your options are and take those and ask for them. If you don't ask, it won't happen. So that would be another bit of advice from my end.
Yeah, those two are so beautiful. And Trang, thank you for that. You know, I think, maybe sometimes it's that it's hard for us to feel reassured, because that was so beautiful. And Mahmoud, I just love that. Like, know what your options are, because sometimes I definitely don't think we all feel that way. David, the one thing that you would like to say to people on the call?
Yeah, I would say that this is a time of incredible opportunities, and yeah, it's going to take a lot of hard work and a lot of collaboration across different stakeholders. But what a great opportunity to transform and change diabetes care.
David, and we'll just go backwards because for our very last question, you know, what do we want to look back on in 20 years and say that we did, and say that we were intentional about, and say that even we wanted to go after if it was really hard? What would you be proud to say happened? What do you want our legacy to be collectively, David?
You know, I kind of got to that a little bit earlier, but that this was, and I'm going to borrow Jeff's term, a catalyst that really did bring everyone together to transform and change the paradigm, to change diabetes care, you know, across the United States and globally.
Yes. Yeah, and this is possible. This is possible. Mahmoud.
Yeah, I would say that 20 years from now, I want to look back and remember 2020, not just as the year of this pandemic, year that virtual medicine came into the mainstream, that this was really the transition year. We've been talking about it for many years before, but this is the year where it became many through the actions of payers, through the actions of regulators, and most importantly, through the actions of people living with diabetes and those who are helping to take care of them on a daily basis.
I would say, just to add on to that, that it's a time where we just get back to the patient about taking good care of them. And that is the most important thing, is making sure that our patients are safe and that they're able to take care of themselves. I hope medicine changes completely for the better. So.
And that if the patients aren't doing well, that there's many more ways for all of us to be upstanders about that and not to have that just happen while no one's watching. Jeff, take it away.
I'm hoping that in 25 years that, all of the participants in the industry, all the players, everybody has come together. As I said before, we're all in this together, and that we've been able to take our colors and our swim lanes and our silos and that we were able to weave them together into a beautiful tapestry that we can all be really proud of, that healthcare has transformed, and that we're now really, truly delivering on all of the, are so steadfastly, committed to, by helping people, stay healthy. And it's that tapestry that I really, really dream about.
Oh my gosh, I know all of us are going to dream about it also, and the 500 people on the line are going to dream about it. I have to say on this note, everyone join me in thanking this phenomenal, phenomenal panel of leaders. Thank you incredibly to all of the organizations that they work with for making so much possible for diaTribe. We can see, everyone in the audience, my thanks to you for spending some time with diaTribe today. Thank you so much to our incredible, incredible team at diaTribe, especially Eliza Scholar and Divya Gopasetti, the co-managers of this evening, Jim Carroll, our amazing COO, who makes everything happen day to day. The sponsors, again, the gold sponsors, Abbott, AstraZeneca, and OneDrop. My heart just goes out to you in saying thanks, and so does all of our team. Dexcom and Sanofi for being silver sponsors. We're so grateful, and so much appreciation to Insulet, Lilly, Medtronic, and Novo Nordisk. 2,700 people with diabetes were diagnosed yesterday in the US alone. And the day before that. And the day before that. And so, I'm with everybody here. Let's make our mantra for these folks to do as well as possible and to enable them to stay healthy, where not all of us have been able to do that, from the very start of our journeys. And let's look out for everyone living with diabetes and their families, and realize that all of us deserve to do as well as possible. One way is using the power of data and technology. And you guys, the power of this is huge. It is foundational. So thank you again hugely much to David, Jeff Mahmood, and Virus Trang for showing us and telling us some of how to do this. Goodbye and farewell. If you enjoyed this, let us know in the chat. And if you enjoyed enjoyed the panel this evening and want to go on to diaTribe, I think you'll get your weekly mailer tomorrow. If you feel like going to diatribe.org/Ella, and just as a tiny note to our team, to say to them, thank you for working hard, even a dollar gift is matched and means the world to us. So on this note, let's see what we can do in the next year and in the next 20. Thank you so much again.